So now we're going to demonstrate retrograde anterior column fixation, but instead of starting on the pubic tubercle of the injured side, we're going to start on the opposite side and cross the symphysis in retrograde fashion for fixation of the, in this case, left anterior column or superior pubic ramus. So I'll take the driving wire and the driver. So it's the same incision and starting point as you would right in the midline. Perfect. So you don't want to go too caudal because then you lose, you start to enter that concavity of the anterior pelvis. So this ought to be a fairly decent starting point. Shot there. So let's make a nice little footprint. Then we'll go to the inlet and you can zero out the rainbow on that. And we'll just make sure that we like the starting point on the inlet view and then we'll just pop it across. So that's a little posterior, that's okay. Shot there, we'll adjust. Excellent. So you could save that and then come to the outlet. And I like a midline incision here. If you go transverse, you risk coming a bit too lateral and injuring one of the spermatocords. So I try to stay as much in the midline with my incision as I can. Excellent. So I feel like I'm about to cross the symphysis there, shot there. And then now that we're just on the, across the subchondral bone on the contralateral side, we'll check the inlet. Good. So we'll just drive this in a bit and we'll bounce off that posterior parasymphyseal cortex, shot there. All right, great. Save that image, come to the anterior or the outlet, and we'll put our opening reamer in. Excellent. So I like the starting point and the trajectory on both images. Shot there. Shot again. Alrighty, so now we'll go to the inlet view and we'll monitor to make sure that we don't breach that posterior cortex of that parasymphyseal contralateral bone. Shot. Alrighty, so our notches have crossed. We're deep enough, we can pull all this out. Put in our cannula. There we are. And then the 2.0 millimeter steerable guide wire. Shot again. Shot there. And shot there. Nope. Shot. So whenever you get into a tough spot and the bone is hard, just choke up a little bit to decrease that length between your handle and your sleeve. Shot there. Shot. There we go. And if you're just starting out and you don't have a lot of pelvises under your belt and you plan on putting in posterior fixation, I always recommend getting your wires in posteriorly first before you go to fix the front. Just because you get a whole plethora of confirmatory oblique views of your posterior pelvis to confirm your wires are exactly where they want to be. Shot again. Great. So again, because I'm using a lot of force, I'm just using short distances here. Shot. So now we'll get our obturator inlet, which gives us a nice view of the inner and outer tables of the ilium. as we try to guide this up that posterior half of the ilium across the buttress. Just going to back this up a bit, adjust my trajectory. Shot there. Shot there. Nope. Like this better. Shot. Great. And then outlet. Excellent. So we're pretty low in the teardrop, so we know we haven't escaped up the ilium. Sometimes that can happen. If you're too cranial in that teardrop, a lot of times you'll cross that incredibly thin area of the ilium. So if you're trying to get this to go above the buttress and get you a longer fixation and more hard bone to end your threaded tip in, want to make sure you stay low in that teardrop. If you find yourself climbing cranially in that teardrop on this obturator outlet view, you may have escaped out the false pelvis along that inner table. So just be cautious of that. So here, I like our point here. We'll just measure, ream, and fire in our implant. All right, so that's giving us like a 176. So you can cheat a little short. Like I said, it'll expand up to 8 millimeters. So why don't we just do that? We'll go with the 170 and we'll end up somewhere in the 176 range. And these flexible reamers are designed to take on a lot of torque, crossing multiple harder areas of the pelvis. There we go. Shot there. Save that image and go to the inlet, the obturator inlet view. Shot there. That's pretty far along the back. This will be good fixation. And these mallets are really well designed. They've got a little recessed area for you to use, pulling these out, and then a flat area to finish it off before you go to your obturator. Great. And the obturators have two thicknesses. The thicker one is useful for the back end of the drill, whereas this thinner one is the only size that will go through the actual reamer to keep your guide wire where it belongs. And as you insert this, it's helpful to just give it some twist. Shot there. There we go. Shot again. Good. Save that. Alrighty, and now we'll put in the 1/6 driving guide wire. Shot there. All right. All right, so now we're going to put in the 7.5 by 170. Again, and this is a good technique for if you have, in this example, a left-sided parasymphyseal fracture and you don't have a good anchor point for retrograde fixation on the left side. You can start on the right side, cross the symphysis, and get multiple cortices that you end up going across. Shot. Shot. All right, good. Sometimes you have to push a fair amount once you hit some hard subchondral bone. A lot of times it's helpful to have an assistant on the other side to give you some counter pressure, even if you have to have x-ray back out. All right, so we're just about down. And with the guide wire out. So this locking device is great because you have a color and then a visual diagram as your two visual cues that you're in the unlocked. or the locked position. So right now I've got red unlocked, got my 15mm wrench on there. And now you feel a little bit of a tactile clip as you go to the locked position. I can see the lock diagram and we have the green color, so we know we're good. And there's your retrograde transphyseal anterior column fixation with your trajectory bending up the posterior ilium over the sciatic buttress.